this video, let us start our discussion on aneuploidy screening. So actually, what is aneuploidy screening? Before that, let us see the general terms and the protocol which we follow here. Okay, so first, aneuploidy. Aneuploidy is a defect in chromosome makeup. It is a defect in the chromosome makeup or number. Makeup is nothing but like number. Okay, so there is some defect in the chromosome and that is called as aneuploidy. And first we need to say what is a normal chromosome number, right? So the normal chromosome number everyone knows it is 46. Okay, so if there are defects in this chromosome number, then that is called aneuploidy. So what are the different types of aneuploidy? Let us check out. The first aneuploidy is Down syndrome, which is most common, right? So Down syndrome is trisomy 21. So what does this trisomy 21 mean? On the 21st chromosome there is one extra chromosome number, right? So that is called trisomy 21. So they have total 47 chromosome, right? So this is an aneuploid, you can say, because there's a defect in the chromosome number. Normally it should be 46, now it is 47. One has increased. That to where that one has increased, it has increased on chromosome number 21. So for example, how to understand this? You know that the chromosome will be like this. So for example, you take this as chromosome number 1. Okay, so chromosome number 1 you have 2, whereas here on the chromosome number 21 you will have like this 1 2 3, you are having 3. So this is a mistake here. So because of this is called trisomy 21, total of 47 chromosomes. So this is first aneuploidy. And the second aneuploidy which we discuss is Edward syndrome. So in Edward syndrome there is trisomy 18, means on 18th chromosome there is one more extra chromosome. Okay, and coming to Patau syndrome. In Patau syndrome there is trisomy 13, means on 13 chromosome there is one more extra chromosome. Okay, and fourth one is Turner's syndrome. In Turner syndrome there is monosomy X. Monosomy X means 44 plus XO. So you know in total there should be 46 chromosomes, right? 44, 45, 46. But here actually there is monosomy in the case of Turner syndrome. Okay, monosomy X. So now coming to aneuploidy screening. So these are the different problems. So how to screen this aneuploidy? That process is called aneuploidy screening. Aneuploidy screening should be done in all pregnant females irrespective of maternal age. So in whatever age the female is, we need to do the aneuploidy screening because we want to see whether the baby have a chance or not. So to detect any kind of trisomy or monosomy, mainly we want to detect the trisomy 21 and trisomy 18. That is, we want to mainly detect the Down syndrome and Edward syndrome are very important. We always suspect to have this kind of defects in a baby. Okay, so very important is every female we want to take this aneuploidy screening. So if the example you take aneuploidy screening test is positive in this female, so now what next? You need to go for diagnostic test. Why you need to go for diagnostic test? Because you want to confirm like what type of aneuploidy is this. Okay, so for that you need to do karyotyping. So what is karyotyping? We'll understand now. Karyotyping is actually a confirmatory test. Okay, it is a confirmatory test. And in the normal, first you see what is the normal karyotyping. In the normal karyotyping you will have 22 pairs of chromosome along with XY or either XX. If female XX, if male XY, and other remaining 22 pairs will be of normal chromosomes, right? So karyotyping mainly requires what it requires? It requires fetal tissue. Okay, and it is an invasive approach, so there's a risk of abortion with this karyotyping. So let me show this diagram to you instead. Okay, let me show this. So this is how a karyotype looks. You can see here the chromosomes, right? Here XY means it represents the male. Okay, so this is a male karyotyping. So what is the defect which you find here? This is a normal one, no defect. Okay, So now let us see the true approaches if the screening test is positive. As I said here before, right? If the screening, aneuploidy screening is positive, you should go for diagnostic test, that is karyotyping. But you have another type that is called as cell-free fetal DNA in mother's blood. So what is it? A cell-free DNA in mother's blood is a secondary screening. Okay, it is non-invasive, so this is better, no chance of abortion here, but it's very costly. Okay, so if positive, then you can go for karyotyping. So for example, you got a one female who have done their aneuploidy screening and you have found that aneuploidy screening is positive. Okay, now you want to make her to go for cell-free fetal DNA. Okay, but some of the female may say it's very costly, they can't afford, so they'll say they'll directly go for karyotyping. Okay, so it's according to the female wish, you can't force them. Okay, so what is karyotyping? You know, it's a diagnostic test, especially in the first trimester. You are going to do chorionic villi sampling. Chorionic villi sampling is done in first trimester. Okay, and in second trimester you will do amniocentesis. So now coming to a pregnant female have previous history of trisomy baby, already she may have previous history, then directly do karyotyping, that is the diagnostic sign, because already she have previous baby, right? So now also she may have chance, so directly say her to go for karyotyping. Now coming to screening test in first trimester, as we discuss here, the first trimester screening test, the best time is from 11 weeks to 13 weeks plus 6 days. So in this time you need to do the test here, a screening test, especially in first trimester. So what test you will do? Coming to the biochemical test, that is a dual test. So why we are doing all this test? We just wanted to know any chromosome abnormalities are present in a future forming fetus, right? So dual test is where we do PA-PPA test and we do beta-HCG test. So what is this PA-PPA test? This is a pregnancy associated plasma protein A. So there is some plasma protein A which is associated with pregnancy, that test, and beta-HCG test. Okay, so why we are doing this test? Because in Down syndrome, someone who's having Down syndrome, their beta-HCG levels will be very high and their pregnancy associated protein, plasma protein A, will be low. So by this you can have an estimate like, yeah, they may have Down syndrome. Okay, and in Edwards syndrome, this beta HCG values are low, and even this PAPPA level is also low. Okay, so like this you can differentiate between Down syndrome and Edwards syndrome. And report ratio mentioned, that is a cutoff. What is this report? So now we need to take a report where a ratio should be mentioned. Okay, and that is a cutoff, that is called as relative risk. So if the report has risk more than cutoff values, then it is a positive screening test. So for this I will give an example. For example, take Down syndrome. In Down syndrome the cutoff is 1 in 250, and in Edwards syndrome the cutoff is 1 in 100. Okay, so what they are saying is, if the cutoff values, if the report has risk more than cutoff values, then it is a positive screening test. So for example, in Down syndrome we give 1 in 250, right? So if the report is saying that this person have 1 in 300, means there is less chance when compared with cutoff values, there's less chance that in this baby they have Down syndrome. For example, if they say 1 in 100, if they say Down syndrome in the report, it's 1 in 100. Now what you will say? In 1 in 100 means there is having now relative risk. There is high risk. You can say the screening test is positive in this 1 in 100 patient when compared with the cutoff, like this. Okay, so this is how we need to measure the differentiate between the cutoff and the report values. Okay, so now coming to ultrasound. So in ultrasound we measure the nuchal translucency. So what is this nuchal translucency? It is actually a sonographic appearance of fluid filled area below skin, below neck. For example, let me draw a baby here, just an imagination. Okay, so for example, this is a baby's head, this is a baby's neck. So behind this, like this, you'll have a dark fluid filled area, and this fluid filled area, dark fluid filled area, this is called as nuchal translucency. Okay, this is a sonographic appearance. So correct way to measure the nuchal translucency is, it should be measured only in mid sagittal plane. Okay, always measure this in mid sagittal plane, and you should see that the head of the fetus should be in neutral position. Head in neutral position. Okay, neither extended nor flexed. It should not extend or flex. It should be in the neutral position, and you should measure this in mid sagittal plane. Okay, and head, neck, thorax area should be magnified. So you can see here I have magnified only head, neck, thorax regions, right? So we should magnify them, and amnion should be separated, should be seen separately. Okay, so this is one more rule, that amnion should be seen separately. Okay, and measured from inner border to inner border at widest plane. You should measure it from inner border to inner border, from this inner border to from this inner border. Okay, measure from inner border to again inner border. Okay, at the, what they mean is, in the widest plane you need to measure this. And the best time to measure this is 11 weeks to 13 weeks plus 6 days. That is according to crown rump length. You can say when the crown rump length is 45 to 84 millimeters, that is the best time to measure this nuchal translucency. So now, if the nuchal translucency is greater than or equal to 3 millimeters, then there are different problems in the fetus. Okay, you will see the problems in fetus. So what are those problems? The first problem is trisomy. Trisomy is most common, especially trisomy 21 greater than trisomy 18 greater than trisomy 13. Okay, and the other one is Turner's syndrome. Okay, and the other one is cardiac defects in fetus. So you will see Turner's syndrome, you will see cardiac defects in fetus, and when the nuchal translucency is abnormal. Okay, when nuchal translucency is abnormal, you should go for karyotyping, and if normal, then we need to do echocardiography. So what I am saying, let me repeat it again. If nuchal translucency is greater than 3 millimeters, then there is some problem in the fetus. So the first problem, it may be is trisomy. It is the most common. In that trisomy also, trisomy 21 is greater, means Down syndrome is greater than, Edwards syndrome is greater than. What is trisomy 13? I have said you before. That is Patau syndrome, right? So this is, and next coming to another syndromes which may be caused, like due to this Turner syndrome, or you may have cardiac defects in the fetus, right? So when nuchal translucency is abnormal, then you should immediately go for karyotyping, and if that karyotyping is normal, then once you need to even check the echocardiography. Okay, so now coming to combined test. What is this combined test? That is, you are doing both biochemical markers and ultrasound. Okay, so you will check for biochemical markers and also you will check for ultrasound. Okay, and the sensitivity, the test sensitivity is 85%, like 85% accuracy you can see in the combined test. So now let us discuss about cystic hygroma. So always we need to be able to differentiate the cystic hygroma from nuchal translucency, because they'll appear same. Remember that cystic hygroma is also a fluid filled area which is extending downward, and it is not restricted only to the neck. Okay, so fluid filled area, it will extend downward. Okay, not only restricted to neck or head like that. Okay, so it is not localized, and it is much more fluid collection than the nuchal translucency. So for example, let me draw. For example, this is a fetus. Okay, and you have fluid like this all almost like all over, right? So this is called a cystic hygroma. Okay, and it is also having some septa like thing. It is presence of septa, and when cystic hygroma is seen, the better marker of aneuploidy than the nuchal transparency. Very important. Cystic hygroma is better marker for aneuploidy, that is any chromosomal defect, it will say it better than nuchal transparency. This is better. Okay, and if seen in, so now let us see if this cystic hygroma, if this is seen in first trimester scan, then it may indicate the Down syndrome, which is the most common. Then it will indicate the Turner syndrome, then trisomy 18, that is Edwards syndrome. So in the first trimester, if you see this cystic hygroma in the scan, then it indicates mostly Down syndrome, followed by Turner syndrome, followed by Edwards syndrome. Okay, and if you see this in second trimester scan, then there is 75% chances of Turner syndrome. Okay, so after this first and either in first trimester scan or in second trimester scan, after this scan you should go for karyotyping. Why you do always karyotyping? Because you want to confirm what type of disease is it. Okay, so in the absence of aneuploidy, karyotyping will be normal, right? Cystic hygroma indicates, so for example, you took karyotyping and you did karyotyping and you find that everything is normal. Okay, then what may be the other indications of cystic hygroma? Then other indications may be congenital heart disease, like you may have hypoplastic left heart and coarctation of aorta. Okay, that means always remember that cystic hygroma not only indicates about aneuploidy. If aneuploidy is not present, then you should see whether these diseases are present. Okay, so for that you need to do, of course, echocardiography, right? And next, coming to some genetic syndrome like Noonan syndrome. Okay, and it may also indicate hydrops fetalis. So this all you need to see. Okay, so next video will discuss this and continue our part 2 of aneuploidy screening.